Okay, so with those antidepressants, the idea is that we have an increase in serotonin right away, but we don't see efficacy of the drugs right away. So there's this lag in time. I'm sure you've seen that on like antidepressant commercials. Like, sometimes they say 2 weeks. I always tell people like 4 to 6 weeks. It's probably better to go longer. But what is happening? Well, we've moved beyond the regular monoamine hypothesis of depression and have gone kind of to a revised version. Here, what we're looking at is neurotropic factor. This causes changes in the brain. It's called Brain-Derived Neurotropic Factor, BDNF, and it regulates receptor growth. And when you have the monoamine receptors, the metabotropic receptors activated, so those would be up here, that's like that second messenger system. One of the things that happens is you'll have an influx of calcium ions, which activates the second messenger system, an increase in Krebs, which then synthesizes BDNF. And that potentially could take a while. It could take like 2 to 4 weeks. So it kind of matches up nice with the lag between the time you take the drugs and the efficacy. So maybe that's it. And BDNF has been shown to be lower in people with depression, and it gets lower as depression becomes more severe. Although we can measure group differences in BDNF, you can't really use BDNF as a diagnostic marker for depression. Although antidepressants, they'll be superior to a placebo. Again, that's what we do in drug studies. So the gold standard is a double-blind, placebo-controlled study, and what you're looking for is separation from placebo in an antidepressant. Placebos work pretty good. Antidepressants work better, but they don't work for everyone. And they do have side effects. Let's see if this video will load here. The side effect profile for antidepressants, I think it's always kind of funny. You'll see it on the commercials, like, at the end of the commercial, man, for some reason that won't work. Well, it doesn't matter. But you'll see, like, the commercial will say, like, this drug may cause nausea, vomiting, dry mouth, sexual side effects, blah, 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 and they'll have a whole list of side effects. So there's all sorts of different types of side effects. Now, bipolar disorder can also be treated with drug therapy. Usually you're not going to see bipolar treated with antidepressants like depression. I don't think this is as severe clinically as it's sometimes made out to be. But if somebody is bipolar and they're in a depressed episode and you treat them with antidepressants, the worry is that you'll switch them into a manic episode. So instead of using antidepressants, typically we're going to use a category of drug called mood stabilizers. So the main mood stabilizers are lithium, Depakote, and Depakine, which is valproic acid or valproate. We also use anticonvulsant drugs, like drugs that are used in the treatment of epilepsy, like Lamictal and Topamax and Tegretol, drugs like that. So these help prevent both the manic and depressive episodes. Here's a list here. Honestly, I don't like this list, so don't pay too much attention to it. Other than lithium, valproic acid, Depakote, Depakine should be over there. This is GABA, penton, and pregabalin. I'd take those out. Lamictal, you'll see that used. Trileptal, Topamax. Seroquel and Abilify are both antipsychotic drugs, but they're also used. So unfortunately, even though we have all these drugs to treat the mood disorders, they're not always the most effective treatment. A lot of the drugs can cause pretty significant side effects, especially like if you're planning on pregnancy. A lot of these drugs can't be used when you're pregnant. They have teratogenic effects. So what do you do in that case? Or what if you have a severely depressed woman that's pregnant, or somebody with bipolar disorder that has a child? Well, there's other therapies. Some of these might seem a little scary, and some of them have been around for a long, long time. This particular one, electroconvulsive therapy, is still used. Down in Florida, you can have that done. I think Jackson Memorial Hospital, they'll still do that there. But I mean, we reserve this for severely, severely depressed patients that have tried like all medications and have failed, or there's a contraindication to using medication in that patient. And usually somebody's going to be like severely depressed and suicidal. And that electroconvulsive therapy, or ECT, it works. It's more effective than antidepressants, and it has an immediate benefit, but still there's some pretty significant side effects. So think about that. I don't know if you would be willing to have that treatment done. So now that we have all these drugs to treat mental disorders, there's been a lot of different effects socially. So the major thing is the process of deinstitutionalization. So back in the 1960s, when these drugs were first coming into use, we had like almost 1 million people in state psychiatric hospitals. That number has just plummeted to about 1/10 of that. And unfortunately, you see increases of mentally ill people in other institutions. Here's an example of a picture from an old state institution. These were popular in the United States and in Europe. The word bedlam, you've probably heard that. That comes from Bethlehem Hospital in London. That was like a nickname. And they used to just basically store people, and they would charge the public to go on tours. The treatments in these facilities were kind of archaic, sometimes even borderline on torture, because they didn't really have any effective treatments. Then with the introduction of the drugs, you see new treatments that are available, and we initiate the process of deinstitutionalization in the United States, where these large hospitals were shut down in favor of developing community-based mental health centers. Well, that was like the grand plan. They followed through on the first part and shut a lot of these facilities down, but they never followed through in building the community mental health centers like they were supposed to. So we never really rebounded from that. And then with the advent of the drugs, people kind of shy away from psychotherapy. And really, I mean, psychotherapy can be incredibly useful, especially for like depression, a lot of the anxiety disorders. I mean, you can cure phobias with psychotherapy. If we really want to look at the psychotherapeutic drugs, they don't cure a single illness. I mean, not one. You can take the whole DSM, look at all the drug therapies, and not one cures one of those illnesses. What they do is they treat the symptoms, and that's it. So a lot of people would prefer to take a pill, like a magic pill, to solve their problem, rather than working with a therapist in psychotherapy. But it's also true, I mean, you're not going to cure schizophrenia or bipolar disorder with psychotherapy. However, psychotherapy can be very, very helpful to those individuals. I mean, I kind of come from the background where you used every tool that's available to you. So you treat the person from the cell to the societal level. A lot of people who are prescribed medications can't take care of themselves. And fortunately, a lot of these medications make you feel bad too. So compliance is really an issue. You have people with severe mental illness that might live on their own, and you expect them to be responsible for a complicated drug regimen. It's difficult, and it doesn't work. People don't take their drugs like they're prescribed. And in the United States right now, we have more mentally ill people in jail than we do in state hospitals. That is horrific. That is really sad. So the prison system here in the United States prescribes huge numbers of psychiatric medications, and we see a huge rise in the prison population after deinstitutionalization. At the same time, they also introduced drug laws that were pretty harsh, like for illegal drugs, and so you have the skyrocketing prison population. So we went from about 70,000 people in jail in the early 1970s to over 2 million people today. And then we also see a rise in homelessness. So deinstitutionalization, then you see the rise in homelessness. And it's a sad state of affairs. I mean, there's a lot of addiction and mental illness in the homeless. I mean, obviously not everybody, but it sure is there. And the fact that we have so many mentally ill people in jail right now is also kind of scary. I mean, that's where they get their treatment. So it's kind of a sad state of affairs, but that's the way it is right now. So if you have any questions about medication for mental disorders, look at the book chapter. I mean, that's just an introduction to this. You can take, let's see, abnormal psychology might go into that a little bit. At Nova, I'm teaching a class right now called psychopharmacology. That will probably be offered, but is a different course number in the future. You might want to look into that. It's really fascinating stuff. So let me know if you have any questions.